I will welcome Dr. Shamshad Beegum, Professor and HOD of Anesthesiology, MES Medical College, Kerala. She was former Professor and HOD, Government Medical College, Thrissur. She was heading the department from 2017 to 23. Medical Superintendent, Government Medical College, Thrissur, 2016. She is external examiner for MD at various universities as well as DNB examiner for anesthesiology and emergency medicine. MCA and NMC inspector. She is a DNB assessor. She has 15 national and state publication, more than 100 presentation. She has a total teaching experience of 32 years. She is a AHA and IRC trainer. We welcome you, madam.
The chairpersons for the nice introduction for me, and also I take this opportunity to thank the office bearers of this South Zone Conference for giving me a chance to participate in this program. And my topic for presentation is resuscitation endpoints. So resuscitation, this is the place where I am working now. Resuscitation endpoints. So when we see a patient in cardiac arrest, we will be starting the resuscitation wherever it is. Now we have, under the leadership of Chakra Rao sir, we have started training all the people to start the resuscitation wherever they see a patient in a collapsed state. So we will all of us are starting it. So where we will be ending this program. So as I have searched, I have found some points that I will be explaining it to you. So the IRC guideline says that there is a resuscitation endpoints for the calls. That is, till the medical camp arrives, another trained rescuer arrives, that is, the victim is revived, or the rescuer is exhausted, or the place become unsafe. So this is only for the calls. And as per the AHA, it says that whenever the signs of rigor mortis seen, indicators of DNAR is there in the patient, that is either as bracelets, anklet, or written documentation is there do not resuscitate, or whenever a threat to safety to the providers. So these are the endpoints. That is only for the BLS. And for in-hospital cardiac arrest, if the asystole is seen in the ECG monitor, or if the entire carbon dioxide is less than 10, even after 20 minutes of resuscitation. So these are the endpoints that is only for the BLS, but for the IHCA patients, it is for the after the ACLS. So I will be saying some of the points. That is, mainly the resuscitation is done from the out-of-hospital cardiac arrest as well as the in-hospital cardiac arrest. In out-of-hospital cardiac arrest, that is, I will be discussing under these headings, that is the chain of survival, return of spontaneous circulation, post-cardiac arrest care, as well as the neuroprognostications. So in the out-of-hospital cardiac arrest as well as in the in-hospital cardiac arrest, as per the 2020 CPR guidelines, they have introduced a sixth chain in the chain of survival, that is the post-cardiac arrest care. You can see that a post-cardiac arrest care is there as the fifth chain. So that indicates a patient in the bed with an ECG monitor as well as temperature monitor. That is both in the out-of-hospital as well as in the in-hospital cardiac arrest resuscitation. So this post-cardiac arrest care includes critical care interventions as well as targeted temperature management. This is described as the fifth chain. In out-of-hospital cardiac arrest, we need the critical care support when we transport a patient from the periphery to the hospital or where the medical facilities are available, and continue with the ventilation as well as the blood pressure support. in hospital cardiac arrest, a multidisciplinary team at management is done, that is the advanced level of care, and the aim is to prevent return of cardiac arrest as well as specific therapy to improve long-term survival. The post-cardiac arrest care, the aim is to improve the patient survival and the quality of life, and most death occurs within 24 hours after resuscitation. And when we start with the resuscitation, the aim is it reduces the early mortality and morbidity by a hemodynamic instability, by multi-organ failure and brain injury. The post-cardiac arrest management can be either in anywhere, that is in emergency department, in cath lab, or in ICU, or in a coronary care unit. The clinical significance is that to the post-arrest brain injury, post-arrest myocardial dysfunction, systemic ischemia and reperfusion responses, and persistent acute and chronic pathology precipitated cardiac arrest. So it requires active support of ventilation, intravascular volume expansion, invasive monitoring, invasive monitoring, and vasoactive and inotropic support. And also the treating the underlying cardiac, the cause for the underlying cardiac arrest, that which can lead on to the neurological outcome as well as the hemodynamic optimization protocols. That also includes the targeted temperature monitoring. So this is the algorithm for post-cardiac arrest care algorithm. This is taken from the 2020 AHA guidelines. It includes mainly the two parts, that is the initial stabilization phase as well as continued management and additional emergent activities. Initial stabilization phase is after attaining spontaneous circulation, we have to go for the management, that is either the management of airway, that is early placement of an endotracheal tube, that is the definitive airway, then manage the respiratory parameters, start with the breaths of about 10 breaths per minute, SpO2 of about, maintain the SpO2 between 92 to 98%, and a PaCO2 of about 35 to 45 millimeters of mercury. And the third part is manage the hemodynamic parameters, that is a systolic blood pressure of more than 90 millimeters of mercury and the mean arterial pressure of more than 65 millimeters of mercury, then and obtain a 12 lead ECG. This is the initial stabilization phase for a post cardiac arrest care. Then coming to the continued management and the additional emergent activities is that consider for emergent cardiac intervention, that is if it is a ST elevation myocardial infarction, or if there is an unstable cardiogenic shock or a mechanical circulatory support is required, and check whether the patient follows commands or not. If the patient is not following commands, that is if the patient is comatose, we have to manage with a targeted temperature management, obtain a brain CT, EEG monitoring, other critical care management. If the patient is responding, that is we can consider it as the patient became awake. And finally, evaluate and treat the rapidly reversible etiologies and involve the expert consultation for continued management. These are, we have to see what are the causes of it, that is given it as the 5 T's as well as the 5 H's. Then application of the post-cardiac arrest care, that is optimized ventilation and oxygenation. These are the things that I have already explained. An unconscious or the unresponding patient requires advanced airway as well as mechanical ventilation. Placement of an airway with a waveform capnography. Use the lowest FiO2 to maintain an SpO2 of about 92 to 98%, and avoid excessive ventilation. How to treat, do the targeted temperature management. Only the intervention to improve, this is the only intervention to improve the neurologic recovery after cardiac arrest. That is, monitor the core temperature, measurement with an esophageal thermometer or a bladder catheter if there is no urine output, or pulmonary artery catheter. And the optimal duration is about only for 24 hours in adults, and if it's a neonate, it can be done up to 72 hours. And the temperature should be 32 to 36 degrees centigrade for 24 hours. And the methods are by rapid infusion of the ice cold saline, isotonic fluid, that is 30 ml per kg, or endovascular catheters, surface cooling devices, or using ice bags. That is the significance of quantitative waveform capnography. That is the advantage is that in the morning we have heard about it in detail. That is monitoring the correct placement of endotracheal tube, monitor CPR quality, optimize chest compression, detect the risk during chest compression, and to identify an organized rhythm. This picture, that is how the EtCO2 should be after intubating the endotracheal tube, that is up to 35 to 45 millimeters of mercury. So, in quantitative waveform capnography during cardiac compression, it should be either the normal one, or you can see that if it comes up to 20 millimeters of mercury, we can continue with cardiac compression, or in the third phase, the asystole has occurred. And the uncertain statements, that is during the maintenance phase of the management, is the level of the blood glucose. That is, usually we keep it as the level of the blood glucose up to 150 to 180 in the perioperative period as well as in the peri-arrest period. And the antibiotic therapy, neuroprotective agents, steroids, all these have got no clear definition of the recovery treatment or the effect of treatment. The treatment either treat hypotension, if STEMI or suspicion of STEMI, coronary reperfusion, and targeted temperature management. And neuroprognostication, it's an accurate neurologic prognostication. Is important to avoid inappropriate withdrawal of the life-sustaining treatment in patients who may otherwise achieve meaningful neurologic recovery, and also to avoid ineffective treatment when poor outcome is inevitable. That is, neuroprognostication is the measure to manage the neurological outcome of the patient after developing cardiac arrest. That is the leading cause of the mortality and morbidity in survivors from cardiac arrest is hypoxic ischemic brain injury. It relies on interpreting the results of the diagnostic test, which correlates with the results with outcome. That is, these are the tests that are usually advised to check the neuroprognostication. That is, the after attaining rewarming, that is, limit the sedation and the analgesics for the patient. And in the imaging, check with the cardiac CT or MRI, and in the electrophysiology, do the SSEP, and in the clinical examination, the status of the myoclonus and the serum biomarkers, that is the serum neuronal specific enolase. That is, in a normal patient, it will be normal. In injured brain injury patient, it will be very high, and if the level is found to be very high, there is the chance of recovery is much less. So, and it should be done within 24 hours, 48 hours, as well as 72 hours. The general consideration for neuroprognostication is it involves a multimodal approach to in a comatose patient. It should be delayed until adequate time has passed, and the teams should have a transparent multidisciplinary discussion. In comatose patients, a minimum of 72 hours after normothermia to perform a multimodal neuroprognostication test, though the individual tests have been done. So, we have to wait after giving the targeted temperature management. We have to make the patient into the normal temperature level and then wait for 72 hours. Then only we have to do the neuroprognostication test. So the recovery means it depends on the patient's cardiac status to continue even after the discharge from the hospital, and it needs specific interventions like neurological recovery and the psychological support for the patient's family, and the rescuers also benefit from the psychological supports. So the take home message is a systematic post cardiac arrest care after attaining spontaneous circulation can improve the patient's survival with good quality of life. Most deaths occur within the first 24 hours after resuscitation from cardiac arrest, and so post cardiac arrest care has a significant potential to reduce early mortality and morbidity caused by the multi-organ failure and brain injury. And to conclude, the key management includes rapid recognition of the signs and symptoms of ROSC and the post-cardiac arrest care, and the resuscitation equipment should be immediately available, and the IRCA as well as the AHA guidelines for COLS and the BLS is the only measure that we have at present to decide the resuscitation endpoints now. Thank you.